Dunn, and I'm a social worker, and I'm going to talk about life review. Key issues in co-constructing meaning from a lifetime of experience. Most recently, I was project director of Project Renew, and at the College of Nursing at Medical University of South Carolina. I now am not affiliated with them, but I live in San Antonio, and glad to be here. The key part of my title here is the co-constructing piece, and I point that out because when we think about life story, we tend to think about that it's their story. But the reality, part of what we know from our research, is that it's a co-construction. It's not only their story, but it's an interaction with the listener. And that's a very, very important piece that I'll come back to. The research that I'm going to talk about, I'm not actually the principal investigator. Barbara Haight is the principal investigator. It was funded by the Centers for Disease Control and Prevention. I was involved in every aspect of the research and had input on it on everything except the original design. So let me talk about the original design a little bit so that you can know what I'm talking about. We screened. I don't know if the other sites can see the slide. There we go. We screened using the Geriatric Depression Scale and a short portable mental status questionnaire. Those with minor depression and without dementia were taken into the study. We screened 726 people. I'm not going to go into the results from the whole study, first of all, because we're not there yet. We're still working on that. And I'm hoping that you have the handouts that cover the results from the screening, and that'll go into it in more detail. I will point out a couple of things. Well, let me go over this first. We screened within a week. People were pre-tested. They were randomly assigned either to a control group. Control group got 6 social visits, or randomly assigned to experimental group. The experimental group got a life review. And those typically were done in 1-hour sessions once a week for 6 sessions. Within a week of finishing, they were post-tested. They were followed up at 6 months and 1 year. The testing, we used the activities of daily living, Geriatric Depression Scale, Beck Depression Inventory, Hopelessness Scale, Scale for Suicide Ideation, Suicide Risk Scale, or Risk Assessment, and Death Acceptance Scale. One of the things we thought might be happening is that the control group got a social visit. So the visit was very light, easy, very sociable. The experimental group got a very in-depth intervention. And I felt like that it was one track was reinforcing socially acceptable answers on the post-testing. The other track was encouraging, the history was to really open people up and tell the truth about what was going on in their lives. And so I felt like it was affecting our post-testing, so we added the Marlowe Crown short form, and we were also interested in dementia, how it might be affecting dementia, so we added the short portable mental status questionnaire at 1 year. I want to quickly try to talk about some of the results. We screened 726 people. We found, and most of that was door-to-door. These were community-dwelling older adults over the age of 60. We found that 35% of those we screened had minor depression. Most of them didn't self-identify as being depressed at all, so it was undiagnosed, and it wasn't being treated. and that was a significant concern. Out of that, one of the things I'm working on is a series of short questions, 4 questions that clinicians can use that healthcare providers can use to screen for depression. One of the things we found is that 82% of those who with minor depression, if you asked, are you in good spirits, which is a normal question to try to screen for that in a clinical setting, 82% of them said they were in good spirits, even though they had minor depression. The other thing that needs work, we found that needs work, is a hopelessness scale. The hopelessness scales available are not for the geriatric population. Over and over again, I heard people say, this is a young person's scale. These questions are not for me. Let me talk a bit about life review and what is life review. And to talk about that, I'm going to talk first about what people are doing when they reminisce. And this is from the work that Jeffrey Webster did. And first thing, they're just bored. So they're relieving their boredom. They're making conversation. They're maintaining a connection with somebody else. So you'll notice these are very social ways of using reminiscing. Another one is bitterness revival. They're keeping old hurts alive. And that's still a little bit social, but it starts to shift into life review material, death preparation. They're preparing for their own death when they reminisce. And again, this starts to be life review. They're also answering the question, who am I? Who have I been? And they're solving problems when they reminisce. This too is part of the life review process. And they're also teaching and informing. And all of a sudden that shifts everything, and so that they're doing what I think of as legacy. They're building a legacy. And so all of those last few things can be that. Now, another point is that it all looks the same. You've got somebody telling a story and one or more people listening to that story. So when they start out by just making conversation, in the middle it might shift to, within themselves, to death preparation, and that get too uncomfortable and move into teaching and informing. And as a clinician, it's important to be able to track that. So that if depending on what your agenda is and your agreement with the client, the two of you working together. So let me look at that side of it. And remember, I said what you might do is social. These are important because it's going to have a lot to do with how you structure what goes on. Reminiscence is used quite frequently and very effectively to create social bonds. Isolation is a big problem. Reminiscence groups can help that a lot. Life review is a very different thing. And obviously I'm going to talk more about that. And then I found that there's a whole host of people across the country who've built a business out of creating legacies by writing books, doing audio tapes, doing videotapes, so that people will have something to give to their descendants. Now, remember that it's all somebody telling a story, but how you work with that as a clinician. So if you're going into, if you decide you want to do a reminiscence group, decide what you're doing. Think clearly about what you're doing first. Are you doing life review? Structure a life review. Are you doing something that's social? Structure something social. If you're doing legacy building, structure, and I'm going to talk more about that. And I'm also going real slow. Life review, in my mind, is a process in which you empower the client to integrate life events and meaning of those events into a compassionate and acceptable self-image. One of the things, if you read the literature on life review, you find that people are talking about vastly different things when they use the term life review. So I'm going to try to be specific about what I'm talking about, and I'm going to use Dr. Haight's definition and what she talks about. And so if you're doing life review, one of the things it's going to have is you're going to span the lifetime. When we worked with someone, we started with, what's your very, very first memory? And we took it all the way through to where they are now. Now this means that there's the potential for any aspect of life. You may hear some really dark stories that are very, very hard to hear in a life review. And that's part of that's part of the package that you take on when you do a life review. And so that means that you need an environment, an atmosphere, and relationship that is safe, accepting, and respectful. And that's not always easy to do, but you work at that. One of the things often you'll see literature about someone who did a piece of research where they were interested in some aspect of people's lives, something they had in common, their experience with being an abusive, whatever, and they ask questions about that section of life, and the people get evaluative, and so they start thinking in terms of doing a life review, but that takes it out of a context of the life. And the life review needs to put those outstanding events, and frequently in a life review you'll hear those up front, outstanding events into the context of the whole life. Okay, what happened to me here? Sorry, my slides are getting weird. Okay, the way we practice life review, it tends to be one-on-one. This is a little bit controversial because lots of people do what they call life review in groups, and they also do life review that's a written form, and those are perfectly valid ways to function. I would encourage people to look at and think about the differences, and I'm going to talk about that a little bit. We do one-on-one, and there's a reason we do one-on-one. And first of all, it comes out of some earlier research that Dr. Haight had done. Now I've compacted this graph because they also did random reminiscing groups, random reminiscing individually, current events groups, and current events individually. This compared group and individual. The difference, I'll come back to the evaluative piece. One part leaves that out, drops that out. But basically, they're doing a group structured, and by structured, Dr. Haight's talking about that it spans the lifetime. And I'll come back to that also. And the individual structured evaluative life review had significant greater advances in the Life Satisfaction Index A scale, Rosenberg's Self-Esteem Scale, Bradburn's Affect Balance Scale, and the Beck Depression Inventory. It was significantly different. So let me talk about why that might be, what I think is going on for that to be true. To do that, I'm going to talk about a little bit about theory. And the first I want to talk about is construction theory. Construction theory says that reality is a construct within ourselves, and that how we decide who we are, how the world is, what it is a construct within ourselves. When someone does an internal life review, in other words, a life review, and this a lot of people, older people do this, not all, but a lot do, and that's what they're working. I also believe that when someone is doing a written life review, that's what they're working, those internal constructs. Now there's a related theory, but different theory, and that's social construction theory. And that says that reality is created in the space between us, and that we behave as if certain things are true within our society. And those are in the space between us, not inside of us, but what we collectively behave as if something is true. Who men are, who women are, what's the nature of being a Texan. All of those things are constructs. What's the nature of a table? All of those things are in the way, and it's behavioral, it's not verbal, because we frequently say one thing and act another way. Okay. In life review, what we're working with is the gap between the two. We've got internal constructs and then the social constructions. And frequently there's a gap between those two. And when you do a life review, you're bringing those two together so that the conflict between the two starts to be resolved. Now this would suggest that group would be a better intervention. And that indeed is one of the strengths of doing group work, is that because there's more people in the group, it more closely represents a social situation, and so they have a stronger voice. It's too easy to dismiss the one clinician doing the life review. So that kind of goes against my point. But group also brings in another piece, and then I want to talk about that. And it brings in dominant cultural views. The marginalized folks are silenced. Those stories of the marginalized folks are silenced. And the other piece of that is that the disallowed stories are silenced. Disallowed stories might be disallowed because of the internal constructs or because of the social constructs. It might be something about, I hated my children. Those are not socially acceptable and tend to be silenced within the group. That's why I believe we got stronger results in the group, or Dr. Haight got stronger results in the group, and it's also why we do one-on-one. So there's a trade-off. There are trade-offs there. I want to point out that not all disallowed stories are negative stories. Stories of power for women, marginalized people are often being competent. Those are often disallowed stories. Thank goodness those are becoming less so in our society, but still. The next piece is that the life review is evaluative. When we say evaluative, I always cringe, because as a social worker, and I know as nurses, we're all trained to assess. And in life review, you're empowering the client, so you're trying to shift that evaluative piece to the client. It's theirs. So the questions are, who controls the story? The client needs to control the story. Who decides what's important? They need to decide what's important in their life. You're working at giving that back to them. Who decides what things mean? They need to be able to do that, and you need to be working with them. So in theory, those are the clients. Now, Dr. Haight always bristled when I said in theory. He said, no, of course it is. But it is in theory, because we were doing research, and in research, the story has a longer life. In practice, the end result is the internal construct. In research, there's something that's going to be written. I'm going to stand up and I'm going to talk about it. And I might talk about somebody's story. The potential is there. And so that's a piece of power that is different in research than in clinical practice. And finally, it's structured. And to talk about, when Dr. Haight firstly wrote structured, what she was really talking about is that it spans a lifetime. I think it includes more than that. Okay, let me come back to this chart to bring in the structured piece. Now you notice that the part that I didn't talk about before, when I had this up before, Could we get the slide up? The part that I didn't talk about before is the evaluative piece. Basically what that meant in practice was that when someone would tell a story in these first groups without the evaluative piece, they would move on and they would tell the next story and then the next story. And the questions would be about what did you do next? What happened next? In the evaluative piece, the clinician says, what was that like? How did you do that? What did that feel like to you? What did that mean to you? All the questions that invite them to evaluate. And that was a key piece. Without it, life review is not really life review. So it's a key piece to do the evaluative piece. Now that also says to me that that's part of that co-construction, because what's different between those groups is something the clinician did, not what we don't know if they actually evaluated. I mean, I've done lots of life reviews where people wouldn't evaluate, but the invitation was there, the space was made for the evaluation. So the evaluative piece is important. It also implies to me that the skill of the clinician comes into play. And that's something that's not been examined or talked about in the research. So let me come back. I'm going to have to slide through the last piece here for the sake of time. But let me come back and look at all of those things in terms of our research and what it might mean in doing and practicing life review or in doing research for life review. So when our people were coming in and they were screened into our study, and we pre-screened them. I mean, we screened them and then pre-tested them. And they were assigned to the life review. Their motivation primarily was to help us. They're going to help us do research. In a practice setting, in a clinical setting, that's not what goes on. That piece is not there. So they bring with them a stigma of possibly needing help, depending on how it's structured. So I think there's a difference going in, and that's an unfortunate thing in doing research with life review. I don't think you can take that piece out. I mean, maybe you can, but it's a problem, I think. We don't know what impact that has. I think if you're planning to do reminiscence work, then I think it's real important that you get clear on your goal. Are you doing something social? Are you doing life review? Are you doing legacy building? And that you get an agreement between the two of you that that's what you're doing, so that you're on the same page. So when they do slide into teaching and informing, if that's not what you've agreed to do, then it's okay to pull them back. Okay, so there were lots of issues in the middle there. A lot of people we found, I believe, a fair number of folks going into the control group were doing an internal life review on their own. And so what looks like a nice, clean design for a study gets less so with this kinds of interventions. Even though someone was assigned into the life review, doesn't mean they life reviewed, or the quality of the life review is a concern. You can tell stories, story after story, without ever evaluating, without having any insight into what goes on. So the intervention wasn't a pill, it's a piece of work, and it's not guaranteed that everybody's going to do that work. Now, to try to deal with that, I created this form, and this, now the bad thing about what we did is that we were only able to ask the clinician. In a perfect world, we would have also asked the client to answer these same questions. And these were, besides the ones you can see on the screen, and I hope you could read them, things like, how much do you think the participant trusted you as a professional by the end of the visits? Did their judgment of themselves improve during the visits? All of these things are things you're looking for in the structure. And the clinician in structuring things is working towards something. They're looking to facilitate the evaluation. Okay. And finally, what's the final product? In life review in a clinical setting, the final product is what they say in their head. They come to a place where they say, well, you know, I had some hard things I had to face in my life, but I did okay. And that's what you're working to hear. You want to hear them say that was hard, but I did okay. Or I did great. Or they'll qualify it some way. And that's the final product. Except when you're doing research. Final product suddenly becomes something different. It's also different if you're doing written life review. You create something, or they create something, and it has a life of its own. And I think it makes a difference in what questions are asked of themselves, what stories are told, and what the stories sound like. And so now this is a lot of stuff that we don't know about yet. I mean, that research has not been done as far as I know. So what are the directions for life review research? A lot of what's being done, or some of what's being done, is trying to find where life review fits in the medical model. Is life review a treatment? And in fact, this study falls in that category. And the question was, is life review a treatment for mild depression? We're not ready to answer that question yet. It's still, although I have my opinion. And the preliminary results indicate that that'll have to be qualified. At this point, I can't say an unqualified yes. My personal opinion is that life review takes too much ego strength for life review to be an intervention for mild depression. Now, again, the jury is still out, but my personal opinion is that we're barking up the wrong tree. Unless life NOS gets added to the DSM, I don't think that life review, it helps a lot of things, but I don't think it is a treatment for a particular pathology, except maybe in cases. What we heard from people was that it changed my life, all the way from it changed my life to having no memory of the gender of the person that did the visits. So it either had no impact whatsoever, or it really impacted people strongly. I think it's a wonderful, I don't mean to denigrate it. I think a life review is a wonderful, wonderful intervention. We're not sure yet how it works or when it works. My personal opinion, it brings us to that next question, and I have a lot of anecdotal evidence, but the research has not been done. I think that life review can reduce somatization, and that folks tend to somaticize their worries, their fears, their regrets. And I think a life review can reduce visits to the ER, visits to the physician, and shorten the duration of illness. That research has not been done. The research needs to focus more on the social context of life review. By social context, I'm talking about that space between the storyteller and the listener. We need to look at that. The research is focused on the content of the stories and the people telling the story. We need to look more at the relationship. Personality is a big issue. Unfortunately, we weren't able to. I tried to find a way. We weren't able to add personality. We know that personality impacts the way people reminisce, but we don't know the impact on outcome. What anecdotally I found that people with a negative outlook ended up with a negative view of themselves. Now, the question for the research, and maybe that can be done, we still have 80 transcripts of life reviews that we're just now getting transcribed. So there's a rich, rich piece there if I get to actually do that. And finally, one of the big concerns has been a negative experience of life review. And I have some bones to pick with that one because we need to carefully define negative experience. In the medical model, pain is a negative experience and is to be avoided. I had very few life reviews that didn't include tears, that people weren't stirred up. And as a therapist, it's not that we're trying to avoid pain, but we're trying to make sense of the pain, and through making sense of it, to tend to alleviate it. So we need to be very careful about what we call a negative experience. Quite often, I would come away from a life review and not know, not be clear where exactly they stood, and that's very, very uncomfortable. To come back a year later and find that they took it, created a life of its own, and that's part of what you're doing. Okay, any questions? I don't know. I'm hoping that we can hear other sites and get questions from everywhere or anywhere. How about if we just throw it open and anybody? Well, you tell me who to ask, and we'll does what, UTPA? Anybody there have any questions? Who else do we have on there? Laredo? Anybody from Laredo? Okay, El Paso? Not yet. Okay. Okay. Well, let me answer a question that's not asked, and this is one that gets asked a lot, and is still being debated, and that's who should do a life review. Part of my training is as a narrative therapist. On my staff, I had 2 psych nurses working with me. I'm a social worker. I also had an RN working with us, and I had a geriatric technician working with us, both of whom had no psych training. I think in a perfect world, people doing a life review would be trained in treating trauma, because you run into a lot of trauma. And I say in a perfect world. I think in the reality is it's a function of time and trust, is that people are doing a life review on their own anyway, and when they find someone they trust and has the time, then they tend to do it with that person. I would hope that professionals who are in the position to build that kind of trust, when they find themselves doing a life review with someone, they get supervision. It's a very hard thing to do. We didn't see the RN and the geriatric technician on our team felt over their head frequently, and they got a lot of supervision, but we're seeing no difference in the results. Now maybe it's not sensitive enough our measurements are not sensitive enough to measure it, but I think the reality is that lots of different people do life review with compassionate professionals. Okay. In the life review, the point is to make room for disallowed stories. Part of what you're trying to create is an atmosphere and a relationship that makes room for disallowed stories. Mm-hmm. Quite possibly. Right. Mm-hmm. Mm-hmm. Right, right. Well, I'm not totally sure what you're asking me, but let me see if I can talk to it. Right, 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 right. Right, right. And see, people make those same judgments about themselves. And that's part of what you're trying to make room to talk about that and work those through. People frequently make judgments about themselves. And sometimes there's that age gap that you're talking about where the values were formed. For instance, I run into women frequently who had no opportunity to develop a career at the time when they might have done that. And that was discouraged and disallowed. But yet today so many women do have careers, and that they will frequently sit and say, I should have had a career. And, and that's part of what you need to work with. And you need to work with the understanding of that gap. And part of those are disallowed stories. The other piece for men is quite frequently is I should have spent more time with my family. And the truth is, at the time, that was not encouraged. You know, you were to bring home the bacon, you know, and frequently, you know, men that did that well and suffered because of it. And that's part of what, I mean, you never know exactly what you're going to run into, what story you're going to hear, but those are the kinds of things that you work on, that you make a space for those. And those are, you know, out of the dominant cultural views.